Hello and welcome to today's presentation. It's about people, the crisis in communications in healthcare and EMS, and how to fix it. My name is Jonathan Bassett, editor of EMS World, and I will be your moderator for today's program. Joining us today are James Woodson, MD, emergency physician and founder of Pulsara, and Stein Bronsky, MD, Chief Medical Director for the Colorado Springs Fire Department and AMR in El Paso County, Colorado. Doctors Woodson and Bronsky will explain how miscommunication in healthcare is killing more patients per year than breast cancer, car crashes, gun violence, and the opioid epidemic combined. Together, they will identify the steps that the Colorado Springs teams took to improve communication in their community. Today's presentation is brought to you by Pulsara. Visit them at www.pulsara.com. During today's program, you will have an opportunity to ask questions of the presenters. Simply type your question in the question box on your screen. With time allowed, your questions will be addressed at the conclusion of the presentation. And now on to the program. Our first speaker today is Dr. Woodson, who will start off with a community case report. Dr. Woodson, thanks for joining us today, and please take it away.
Thanks, John. Appreciate the introduction. So today we're going to be talking about the communication crisis facing healthcare. Specifically, we're going to dive into, well, how does EMS contribute to this problem and how EMS can help address this problem. Then we'll go on, and Dr. Stein Bronsky will be joining us from Colorado Springs, and he will be talking about the role of EMS in uniting his community, basically go through the change management, some of the ups and downs of change management through this process, and then really come back with a summary as far as, well, is it worth it? Is it worth it to address this issue and problem that's facing healthcare? So the first thing we'd like to do is really take a step back and ask the question, what is the role of EMS? So not just the role of an individual that's in EMS, but what is the role of EMS as an industry? So is it more of just a simple method of arrival, the front line of defense, or are they truly a member of the healthcare team? In the community, are they a leader or are they a follower? Are they an agent of change and innovation in their community, or are they one of the factors that's a resistance to change in their area? So do we focus on the patient when we're just touching them, or do we focus on the patient's ultimate outcome? So I think these are questions that we need to ask, not just on a national level, but also your community and your local level. Those are things that we really need to think about and challenge. And I think that's a good introduction to really dive into what is the communication crisis? Where is it coming from? Why don't we talk about it? Why don't we hear about it more? So on your screen, you'll see several very high-profile things, and these are really big deals that we're often faced with. For instance, how many of us know someone that's been affected by breast cancer? Gun violence right now is a particularly raw topic and subject in America right now. The opioid epidemic. Most of us are really struggling with and dealing with the opioid crisis. We could go on and on with examples of this, but it's really important, if you just look at these on the screen, what causes more deaths than all of these combined? The hard answer is we do. I contribute to this. Most of the people that are joining this webinar today contribute to this. Basically, medical errors actually cause up to 400,000 deaths per year. That's a big deal. We actually cause 10,000 serious medical complications every single day. This costs the industry about $1 trillion a year. That's a massive, massive personal and economic effect. And 80% of these medical errors come because of miscommunications during transitions of care. So how many transitions of care do we go through in often simple EMS cases? We'll take one of the more simple things of something like a STEMI. So basically EMS, let's look at the communication specifically that EMS uses. So what we'll typically start off with is a old-fashioned radio report So we'll pick up a 1970s radio, then we use a 1980s modem to basically bring in something like an ECG so we can transmit that over to the hospital. At the hospital, they're typically receiving that via either a blast, email, or a fax. Then EMS shows up at the hospital and they have to repeat that same oral report that they just gave 1 or 2 more times. Then at the hospital, basically the first person that takes that report is really a radio or phone jockey that's never going to touch the patient, but basically start hollering instructions to other people. We typically set off systems that have blast pages. We go from the blast pages to multiple phone calls, one-off discussions, trying to keep up with everything, repeating the same conversations over and over. So what if this is a transfer? Well, basically it's that whole mess, but on top of that, you're trying to put a transfer center in the middle of that, and then the whole process of involving EMS again. So look at the technologies that we're using: fax, radios, email, phones, pagers. That's how we're communicating in healthcare, and that's just a simple system of one hospital, maybe a transfer thrown in. What about if we're trying to actually do something more complex, like in Colorado Springs, multiple hospitals, multiple EMS agencies, they're all using their own technologies. We have to figure out how to communicate in the pre-hospital space, how to communicate in the intra-facility space, meaning basically teams that cross multiple departments, as well as in an inter-facility space. So I have North Carolina, that's where actually I did my medical training, and we basically dove into research in regional systems of care. One of the things about regional systems of care, especially when it comes to STEMI, we often focus on ECG transmission. Well, regional systems of care and communication is far bigger, far much more complicated than just figuring out how to transmit an ECG. If you look at basically the method of arrival, if we're only focused on pre-hospital ECG transmission and that's our solution to regional systems of care, only half our patients are coming in by EMS. We'd like them to all come in by EMS, but the fact is both our data and the national data, they don't. If you look at things like stroke, up to 2/3 of people are coming in by personal vehicle, and up to half are transferred at some point during their process. So if we're thinking about communication, trying to solve regional system of care communication, we've got to think broader than just the pre-hospital space. This is an EMS-focused webinar, but we have to think for and look for a comprehensive solution to address this problem. The problem is that we have, especially with all these archaic means of communication that have been around for decades, we've put all of our team members in communication silos. The only way you can bridge one silo to the other is a simple chain. Basically, you can only link them together one at a time. And so what we're seeing, if that chain breaks once, that system is in trouble, and specifically that patient is in trouble. The chance for medical errors and miscommunication goes up exponentially the more complex and complicated this team gets. Having different process and protocols for all these different methods of arrival, for all different time-sensitive emergencies or any cases that need to transfer across different healthcare entities is a problem. So the Pulsara solution, the Pulsara tool, basically is real-time team communication across healthcare entities. So if you break that down just a little bit, real-time, it has to work in real time. The data in our EPCRs, in our EHRs, it's not there yet for what we need for real-time care coordination, patient logistics, and moving these patients around. The next part of that phrase is communication across healthcare entities. So we need to be able to have a central hub for communication that you can rapidly build a team that crosses multiple EMS agencies, multiple hospitals, and multiple departments within those hospitals. That's what the Pulsara tool specifically is. The key thing, once you basically provide this type of platform, there's all kinds of things that you can do with it. You can provide instant feedback to all team members to really help close that loop. But one of the key things that we really have to focus on is this communication crisis is real. It has both massive personal as well as economic implications. So we as communities and healthcare leaders, we need to recognize and prioritize addressing this critical issue. So this simply requires change, though. And so it's very important. We talk a lot about technology, but solving a problem like this is much bigger than technology. I think one of the things that you'll hear with Dr. Bronsky is not just things about the Pulsara tool, but also the Pulsara people, the team that we go into a community and basically help that community figure out how to go through the change management and operationalize basically solving this problem together. So Dr. Bronsky will talk a lot about the why and the how his community recognized and started to address this communication crisis head on. If you guys do want to see a demo of exactly what Pulsara looks like, please feel free to go to pulsara.com, where you can see demo videos and learn more about the platform. But for now, I will transition over to Dr. Bronsky.
Thank you, Dr. Woodson. And now we'll turn to Dr. Bronsky for the second part of today's program. Please take it away, Dr. Bronsky.
Well, thank you. And my name is Stein Bronsky. I am the Chief Medical Director for Colorado Springs Fire Department and Medical Director for El Paso County, Colorado AMR. And I work as an emergency medicine physician for Centura out in Colorado. Just so that we can set the table here and you understand a little bit about our community, the city of Colorado Springs is approximately 650,000 people. We have 4 major hospitals, 2 hospital systems that each have 2 hospitals, another small hospital that just opened up that belongs to one of those 2 systems. We have approximately 50 feeding EMS agencies into those hospitals. And out of all of our 911 calls, we have about 65 to 67,000 medical calls per year right now. So our community, I believe, is pretty average with EMS communication. We like to think of ourselves as a pretty progressive EMS system in general, but when it comes to communication, I feel that we're pretty average, and we dealt with communication the same way that everybody else did, which is that we have these historical ways of communicating between the EMS agencies and between the hospitals and EMS agencies, and nobody ever really questions how that communication is done or if it's doing a good job or not, because that's just the way that it is, almost like a commodity. We have downstream communication like everybody, where we're trying to feed information from the EMS system into the hospitals and then back from the hospitals to EMS. And we deal, like many other communities, with the historical problem that we drop off patients, and then we want to know the information about patients and what's happened to them. We typically wait a tremendous amount of time to find out what those results are. Sometimes sooner, sometimes later, but it certainly is not as efficient as we would like it to be. We also have multiple types of communication historically. Everybody has radios. We have fax machines and faxing from the monitors. We use biophones to call in. There are all sorts of historical methods that are used depending on the EMS agency and if they have radio channels available, and all the typical types of arrangements that each system may have can be different from the next system that's just right next door. What this results in, even though I don't think that we acknowledge that very often, is a inefficiency in the continuum of patient care, because we are using these methods of communication that really are in sequence. And I like Dr. Woodson's slide with the chains, because to me that summarizes everything, where if you have one break in the communication chain, if that link breaks, then things break down. And it's really bad for the patient, because ultimately it takes a while to recognize that something has broken down. And even if you do recognize it, you might not be able to fix it right away. So where do we begin when PostSarah came to town and was introduced? I think that we deal with change like everybody else, where you present an issue and you present a solution. And just by human nature, nobody really likes the idea of changing because it's uncomfortable. And we do our best to try to move past that when it came to PostSarah, because I really noticed, as well as other people noticed, when we were introduced to PostSarah, about what could be the possibility of what our communication system would look like if we were to adopt a platform like this. And anybody who's worked in pre-hospital care, be it EMS or law enforcement or anything to do with being out in the field, we all know that it all stems and all is based on how good our communication is. And whenever we have time critical incidences or disasters, everything boils down to how well you can communicate, to how well things go and how smoothly everything happens. And so our initial challenges were, how do you tackle this when we have over 50 EMS agencies? How do you tackle this when we have numerous hospitals and even numerous hospital systems? How do you get people to admit that maybe they have room for improvement? And what do you do with the agencies or the service lines within the hospitals that may give up some resistance because they think they don't need any help with getting better? And then specifically to Colorado, one thing that we always need to consider is how well is any type of communication going to work with our terrain and geography, which is a huge challenge. And then you have the never-ending competition, not necessarily between EMS agencies, but between hospitals or among hospitals, where they all want the competitive edge. And one hospital system may want a program or format like this, and they don't want the other system to have it because they think that they'll have a competitive advantage if they're the only people that have it. So what we did when we started was I and a few other people started talking to PulseSarah. We then had to go to our community and start talking to all the hospitals and the service lines and EMS agencies to get a feel for collaboration and to set up this type of collaboration. The challenge was that we really wanted to do this as a full community all at once. We didn't want one hospital system to start and then by slow process bring more and more hospitals on. There's nothing wrong with that process, and I know that PostSarah has done that in many communities around the country. But for us, we really wanted to try to get our community as a community together and say we were going to make this change all together for the benefit of patients. And so we were able to get everybody on the same page, at least theoretically, and start the conversation, which is all that it took. The kind of secret that I always tell people when we talk about this from the EMS side is that we had to be able to convince the hospitals that this was their idea. Why was that important? Because somebody has to foot the bill. And typically EMS agencies are not the source of the finances in a project like this. And plus, the way that PostSarah is built as a communication system, it's meant to go from the field to the hospital and then all the way up the hospital service lines. And so the hospitals really have to take ownership of it. And if EMS were to come to the hospitals and say, hey, we have this project or this type of system we would like to implement, but you have to implement it on your side, typically, at least historically to me, the hospitals were less responsive to that. Now, if we could sit the hospitals down with Pulsara and say, why don't you just have a conversation with them and see if Pulsara has something that they could potentially offer you to make your system better within the hospital communication, that was the key. And once the hospitals recognized how this could help them, then it was just easy for EMS to tag on. And then if we did our job right, which I think we did here, by the time we got this thing implemented, everybody had forgotten that this was really an EMS initiative to make this happen. And that's the way that I think it worked out well for us. So I mentioned that the hospitals really have to take financial ownership. Within the hospitals, the service lines need to buy into this. And main service lines for us were the neurosciences, cardiovascular, and the emergency departments. I think that would be pretty similar in most other places. The administrations of the hospitals really had to take ownership of this, not only financially, but also as the champions of monitoring and pushing people forward. I'll talk about that in a little bit. I didn't really recognize that in the early stages of this, but it became a crucial factor. IT services, obviously IT is a huge deal, and to be able to coordinate this and to mesh the Pulsara system into hospital systems, it takes the buy-in of the hospital and EMS agency IT services. And that's something that does take time, and Pulsara has been incredible about coming out and making sure that every little rock is overturned and that they're helping to solve every issue, because we have learned that all the issues are solvable. We just have to be willing to look at them. So and with the hospitals, all of the hospitals did go online the exact same day, all 4 of them in our city. So as far as EMS agencies are concerned, they had some maneuvering they needed to do also. For the EMS agencies, the Pulsara application is free, but it always comes with some sort of cost, because we had EMS agencies out here that didn't have smart devices. They used radios, and they used flip phones that were provided by their services. For instance, AMR didn't have any smart devices. And so we needed to make sure that everybody had the hardware that they were going to need in order to use Pulsara. And so that took a little bit of time. And then also, as I mentioned, we had multiple EMS agencies, 50 that feed into our 4 hospitals, but 19 of them that are the core agencies that provide most of the patient transports to these hospitals. And so we had to work out training programs to train all of these people. And as anybody who works in EMS knows, we have armies of people to train out there. And initially I was a little bit concerned about how that would go. But in the end, what happened was that this program and this technology is so simple to use and so intuitive that literally we handed it out, gave them a few-minute video on how to watch it. And even if they did or didn't watch the video, they could just open up the application and figure out how to use it by themselves, just because it functions the same way that modern life functions with any other smart application. And so it was really very, very easy to train them. Interestingly enough, the main fire districts out here had forgotten to do their training. And I didn't discover that until the day we were rolling Pulsara out as a full community. And just within that day, that agency had no problem using it because it was just so intuitive and so easy to use. We did get all 19 EMS agencies that are in and surrounding the city up and running on the same day with all 4 hospitals. This is just a graph that shows you, we started it in July of last year, and right out of the gates, we had a push to use this, and they were using it for STEMIs, they were using it for strokes, to communicate with the hospital. And right out of the gate, the very first month, we had 88% of the STEMI alerts coming into this particular hospital, which is Penrose, Maine. They were alerted via Pulsara. St. Francis had some, not some glitches, but their reporting was not very good on this, so it had been left at 0. But in August, Penrose Hospital and St. Francis Medical Center, you can see they had a little bit of a dip as we were getting everybody on board and working out some of the technological glitches. But then by September, we had 100% across the board, and there were no STEMIs that arrived to the hospitals through EMS that were not activated through Pulsara. And this goes to show you for strokes also, the July, August, September, where there was the ramp up. But once we got into using it for a couple of months, it was the standard, and only if we were on a mountainside or couldn't call in because we didn't have any cell reception, they would use radios with the repeaters. But essentially, everybody was up and running nearly 100% just a couple of months out, and that I believe is absolutely phenomenal when it comes to dealing with such huge numbers. You know, literally thousands of EMS employees that are all going to have to learn how to use this. So what are the benefits that we've noticed from doing this? Well, in the emergency departments, PostSarah allows us to pre-register a patient. We get HIPAA-compliant information beamed right to the hospital through the app. And the hospital emergency department can pre-register a patient, and then they can have everything waiting for that patient instead of a delay in patient care while they register them when they hit the door, and they can't go to CT scan yet, or you can't order the labs. And you really can't start treatment very well at all without having them registered. So that pretty much just evaporated with the advent of Pulsara, which I would say was one of the largest fundamental shifts that got everybody to buy into this. You can also monitor the patient the patient's status in the care process, and what I mean by that is that as Pulsara communication goes up the service lines from EMS to the emergency department and then up to the neuro lab or the cath lab, you can actually see the information about the patient through the application as these different units within the service line are feeding in the information about the patient care. And so it's really real-time patient information, which is fantastic, especially for EMS, because before they were not able to really get any information about these patients until much later, usually. You can monitor arrival time. This was something that we never expected. We weren't looking out for. We were not anticipating that we would even use this. But one of the things that inherently Pulsara does is that it tags the EMS agency where they are on GPS and gives an accurate ETA. So what we did was we lost that universal will arrive in 5 minutes patch, and we really knew how long people were going to take to get into the hospital. And why does this matter? Well, it may not matter as much for EMS, but for the hospitals, it really matters, because if you are calling an alert on somebody, that usually means that resources going to other patients have stopped so that we can wait and spend these resources on patients that are arriving, meaning a CT scan will be cleared. No patients that are in the emergency department will be going to that particular CT scan because they're waiting for this EMS crew to arrive with a stroke alert. And that you could imagine that if we knew that they were 20 minutes out and we could really get that accurately documented, even though the crew gives the 5 minutes out, we know they're 20 minutes out, and we know that we can get another patient into the CT scanner, but we can still have it clear when the patient arrives. And you could extrapolate on that with laboratory services and everything else, how you move beds around in the emergency department and staff. And it also allows the facilities to bypass the cath lab or get to the CT scan faster. And I'll talk a little bit about that here specifically. So for instance, with the neurosciences, with Pulsara, we'll be able to see the patient in the field. And we're still working on some of that application, but ultimately that will be a huge benefit for a end user. And I refer to like the interventional radiologists or the neurosurgeons, the people who are actually be performing the definitive care on these patients. When they are attached to the Pulsara system, they can then communicate directly through the application to all the way down and out back into the field, and that is invaluable to have that type of direct communication. It also improves the efficiency of the personnel, like I talked about, that they can they really know when they're going to need to use certain personnel within the hospital based on information that can be sent over by Pulsara that normally can't be sent over by traditional communications. It improves the patient flow because we can pre-register them, we can get them into CT scan faster, and it really does decrease the time we notice in our system to get a CT scan or get the patient to intervention. I have loads and loads of slides that show numbers and the stats of how our hospitals have improved with that, but I just have a couple I'll throw up here. And this was from last year, where we had from January all the way to September, when we actually implemented the Pulsara for this one service line and started documenting this about patients getting the CT scan. You can see that in general, what happened was that the time from that the patients spent to get to CT scan were much less after we implemented Pulsara, and this has really gone down and plateaued out much lower than it has traditionally. And so it really does save time. It really does give patients better treatment. So for the interventional cardiology, the benefits that we've noticed there is that because the interventionalists, because the cardiologists are actually tied to Pulsara, when the alert is given from the field, not only does the emergency department get the EKG, but the interventionalist gets the EKG right away. And they can look at it and they could say, oh yeah, this is a left bundle branch block that doesn't meet the Scarbosa criteria. No, that's not a STEMI. Let's stand down. That also is very valuable to be able to stand alerts down. But at the same time, they can see the EKG, they can verify, and they can mobilize. And ultimately, that does save time, because typically, at least in our system before Pulsara, we did have a lot of interventionalists that say, I don't really trust exactly what EMS may be saying. And so I'm going to wait until they get to the hospital and let's let the doc and the emergency department look at this, and then they can call me and tell me if it's a STEMI or not. And so it worked well for the interventionalists like that, because they could decrease the amount of false positives. But for the patient, it was not good, because when they are a STEMI, you want that activated straight from the field. So as far as benefits to EMS, one is that it's minimal to no cost. Two, it's pretty much the eradication of EMS and hospital discrepancies in their data. I can't tell you how much of my life I wasted as an administrator going and comparing the data from the interventional services to when they said the STEMI started to when EMS said it started. And that all, as you know, can affect the way that they report the information. And so we were constantly, it was just the status quo that we were always arguing about that. Well, once Pulsara came online, we've never wasted a breath about it again, because everybody is on the same clock. The clock was started at the same time, and there's no questioning it. As I mentioned before, the benefits for for the ease of use are incredible. You don't have to show people how to use this thing, really. You could just say, here's the app, this is what we use, and not that we do that, but you could, and they open it up and they could just run through it. It's just that intuitive. And also it does provide, the potential for the immediate feedback, which is a very precious commodity in EMS. And then, of course, we can't ignore what the benefit to the patient is, because simply we're able to provide faster and more efficient care to them. We can streamline their care. We don't have the delays from the breakdown in normal communication, and or I should say historical communication. And ultimately, that means that we can provide better patient care. So quickly, at the end here, I'm going to just run through a couple of things of where we are moving now in a kind of second phase, and then say where we're dealing with some challenges. Because I think that it is important not to just paint, a picture of all roses and rainbows, but to really tell you also realistically where we do have our challenges. So where we're moving now is that we've moved into Pulsara General Alert, where we're not just alerting STEMIs and CBAs, but we're moving into EMS communicating with via Pulsara to the hospitals for every patient type. And this has been really wonderful in a lot of ways, because one, it takes away the problem that we all know, where you get the muffled or cutting out of the radio patches and you got to ask for them to repeat, or you're waiting for the 6-year-old to arrive at the emergency department and they arrive and they're 60 years old because that didn't come across clearly. And those examples go on and on and on, and everybody deals with them on a daily basis, and nobody really even says anything to suggest that there's a better way to do it. And this has really solved that problem when the general alert is used, because we're communicating through texting, typing into the app, and there's no way to misinterpret what's been put in there. And it also solves the inevitable problems when EMS will say one thing and then somebody writes down something else, or they switch numbers on blood pressure, and the patient arrives and they're really hypotensive, but they had written down a normal blood pressure, and it solves all those problems. It also creates electronic logs for the hospitals, which a lot of them don't have when it comes to EMS. They just have reams and reams of paper that sit there on shelves for years and years and years of all the radio patches that come in from EMS, which obviously is not queryable. It's very difficult to use that information, and this solves that problem. So we're excited about moving forward with the general alert. So where are our biggest challenges right now? I think that the culture is sometimes difficult to change. And as I mentioned on that previous slide, boy, some people are just so resistant to change. And we met resistance along the entire way in little bits and pieces. We had more than expected resistance in some emergency departments, where charge nurses would say, I can't handle carrying around the iPhone or the iPad, and it just makes my life more difficult. And if that person has some influence on the administration, then the administration doesn't necessarily come back and tell them, well, we really have to work out these problems. They just kind of leave it be, and then what's happened is that particular employee has won their personal battle there, but it is not doing good for the system. And we ran into that quite often. I'll tell you how we're managing to get past that, though. And also EMS. There's some people, we all know that there's a lot of people out there that are going to be buried with their radios. And it's been a challenge to get some people to use a modern day application, because it is an operational change. In general, the younger population hook right onto this because it's the way they communicate in real life. I'm proud to say that we have people that have worked as paramedics in our system for 40 years, and they were some of the first people to adopt using Pulsara and don't use anything else. And so I know you can teach the old dog new tricks, and it really kept us moving forward, trying to get everybody else on board. The fifth hospital that I referred to, we have a small fifth hospital that opened up within the university system with a fully functioning emergency department. It's not a freestanding; it's a full hospital. But it was interesting that the months that they went to open, and we started talking about how we were going to get EMS traffic there. The city of Colorado Springs came back and said, "Oh, we're really sorry, we've run out of channels for our radios, and you don't have a slot, and we're not going to reprogram every single person's radio in the entire city just to give you guys a channel." And so they were left with no radio communication with the EMS agencies. And so what we suggested was, hey, this would be great. Let's just go ahead and use Pulsara General Alert as the primary way that people communicate with this. And it was amazing because there was no resistance, because there was no culture that had been built at that hospital to resist it. And people just went right out of the gates, and it was the primary way of communicating, and it remains that way today. And that, to me, was the ultimate proving ground that most of the problems with Pulsara are perceived, and that they are not real, because in these certain circumstances they don't exist. So that's been very interesting and very telling in our community. One other thing that we've run into is that in the various service lines, the neurosurgeons or the cardiologists get frustrated. Maybe they didn't get good information about how to use the app or understand exactly where they fit into the process. They tried it, they would get frustrated, and then they would just take it off their phones. And then they would just simply say, I'm not going to use it. Others really attached to it and have been real champions for it. And this really went across all the departments. And so what do we do about that? So we actually went to the hospital administrations and said, we need you to be the champions of this. This is your system, this is your hospital, this is your communication, and this is not an EMS thing. And you have to be the ones that are instructing your employees and your partnerships to coordinate and use this. And once we got that buy-in from the hospital administrations, they were the ones that then took a renewed interest in making sure that it was not just implemented, but now running smoothly and being responsible for working out the kinks as they came along. Because one thing that we've noticed is that when we started this as a full community, it meant that no one entity was really responsible for it. And so we had to figure out a system where everybody would be responsible for their part, understanding that it affected everybody else around them, even if they weren't initially considering that. So in the end, we still deal with some terrain issues. We still deal with some places where we just cannot communicate by cell phone. We deal with that all the time, and that's just a reality of living in Colorado. So that takes away our ability of always having 100% ability to use this. We also are eagerly awaiting Pulsara's upgrades, where we can transfer patients electronically from one EMS agency to another, because we have a lot of agencies that will begin the work on a patient and then transfer them to another agency that will deliver them to the hospital. And at the moment, they have to restart all the work again on Pulsara, and that causes duplicated work for the EMS agencies, and we don't want that. And Pulsara is working very diligently on making that fix so that we can move into the future with that. And I do believe that that one fix is going to be the tipping point where there will no longer be any major reason that people in the field and the hospitals don't use Pulsara. We've also noticed that some people complain a little bit about the phones being a little bit small and typing, and that we're noticing that tablets are working better for us. So the hospitals have now taken this ownership to make sure that the process is moving on very well within their own systems. We did sit down as a community and said, okay, we've been using Pulsara now for 1.5 years. Where are we? What do we like? Is it worth it? We have many challenges in front of us. It's going to be an evolving process. And do we want to continue? Or was this just a nice, pet project, but we are going to set it aside and say it was a good college try? Unanimously across the board, all the hospitals and the 2 hospital systems, as well as the EMS agencies, all came back and said, yeah, for the frustrations of the little bits and pieces here and there that we're running into issues, and we know that we're still not at, at our perfect bullseye goal, everybody agreed that fundamentally this has changed our ability to communicate and created much better patient care, and everybody wants to continue and has agreed to work on any of the issues that stand in front of us. And so where we're looking in the future is to really fully integrate the general cases and the general alerts, to add other service lines like trauma and internal medicine for sepsis, and then also to trial a medical control application that's coming down through PostSarah, which I think would be extremely beneficial. Work on the patient transfer that I was talking about. Work on the live video conferencing so that we can actually get real-time visual information. And then one really important piece is that we know that we don't always just want a single gadget for every type of thing that we're doing. We don't want a EPCR on one device, and then Pulsara on another device, and then having to fax something on another device. We want everything as integrated as possible for ease of use, and so integrating Pulsara into the EPCR systems is going to be key in where we're moving in the future. And that's about it for me and the summary of Colorado Springs, and I hope that was helpful.
All right, thank you, Stein. So we have a bunch of questions that have already started rolling in, so very much appreciated, everyone, and you can continue to submit questions, and we will answer as many of these as possible. So the first question that we'd really like to dive into, we have a multitude of questions that are asked really around connectivity. And I think the most important thing to keep in mind is the funny thing about communication, you have to connect with people. And so when people are separated by distances, you have to have connectivity of some sort. So this is obviously an app that downloads to your smartphone. If you look at the infrastructure that is being invested in, the infrastructure of the future, it is mobile technology based. And so if you're looking at where resources are being placed, it is in that infrastructure. Now, one of the benefits to Pulsara is we can connect via Wi-Fi, via a cellular network, and for the main alerting, we can even roll over to pagers if you're in a dead zone. But just like it's a limitation with any technology, any of the archaic technologies that you use for communication, it's a simple fact to communicate, you have to be able to connect with each other. So a couple of other questions. One was about disaster, like what happens in disasters where different things go down. I can tell you an example in East Texas where electricity went down, Wi-Fi went down in a bad storm, and the only thing that was working for paging and alerting was Pulsara. Because instead of having just one method for connectivity, we have multiple. but again, that is a limitation. Another question was around kind of how much data is this being consumed, how much connectivity do you need? To run a case without images, it's tiny, tiny, tiny little packets of information. And so that connectivity is very, very easy. Obviously, pictures or video will be more and more. One of the other questions was about FirstNet, and I can say that we are working with FirstNet. We don't have to do anything special to Pulsara. Basically, Pulsara works as an app. It just needs connectivity. FirstNet is another means of connectivity. It's a reserved bandwidth. In fact, at their headquarters, they actually have or will have in the next few weeks a version of Pulsara that they're working with and able to demo to people. So I think that answers a lot of the questions surrounding connectivity. Stein, you might have some other comments about more practical applications of connectivity in a rural area.
Yeah, well, out in Colorado, along the Front Range Mountains, we deal with a lot of connectivity issues. One block will have connectivity, the next one we will not, and that's just something that we live with. To be honest, definitely Pulsara is not immune to that. We do have certain circumstances where information will be put in and we have a challenge on sending that information, but it's really no different than the same issue we have with making a phone call. So we know that, okay, on this block we can't send that information right here, but 60 seconds later we'll be able to transmit that information no problem. So it is something that has room for improvement, but is not a rate limiting or usage limiting factor for us.
Perfect. Thanks, Stein. Here's another question for you. It's really centered around how many, what's the volume in your region, specifically during the the pilot period?
Yeah, the volume, as long as you're talking about STEMIs and CVAs specifically, the volume hasn't changed from the trial period through now. We have, in the first 3 months of setting up Pulsara, we had, give or take one or two, 74 STEMI alerts that came in and 138 CVA alerts that came in using Pulsara. And that's just from the main EMS agencies right here in the city of Colorado Springs. It really does not encompass the counties surrounding it. And but that gives you a general idea that it's a pretty high volume.
Great, thanks, Stein. The next question, we have several that are really surrounding integration, asked in several different ways. So overall, does Pulsara integrate with other technologies? So the answer to that, really, we are built where we can. In fact, we're launching our integration strategy this fall, and we've already selected our first partner to do so as well. But I think it's very important to keep in mind how and why we built the system the way that we do. We believe very strongly that it must work out of the box. So we focused on integrating people first, and then we can come back in and integrate the technology second. But that's the only way. It has to work out of the box. That's the only way you can bring up a region as complex as Colorado Springs or even cities that are 10 times that size. If you go in there with an integration of technologies first mindset, it's going to be very, very complicated. So we need to be able to flip a switch and go live in a single day. And if integrations break down, Pulsara is still functional. But we do definitely see the value of integrations, and we are starting that process now. All right. The next question, Stein, there's a question. What's the biggest lesson learned from the hospital side about implementing Pulsara, and what would you have done differently if you could do it all over again? Yeah,
that's a good question. You know, as we mentioned in the webinar, we went live as an entire community with both of our hospital systems, all of our hospitals, and over 19 EMS agencies all on the same day. And we watched the process move on and get more integrated into our system and more used as the days and weeks and months moved on. I would say that as we turn around and look back at the process, probably the biggest lesson learned and what we would do differently, not only from the hospital side but also from the EMS side, is to clearly identify people within the system, both on the hospital side and on EMS side, that really are the champions, the ones that are tasked with the responsibility of making sure that PostSarah is running smoothly. The application itself doesn't need any help running smoothly. It's very, very simple. It's the coordination among all the different agencies and hospitals and service lines within the hospitals that we realized was common ground, and no one entity or service line felt as though they were ultimately responsible for making sure that it was moving smoothly and that glitches were worked out. We were eventually able to figure that out. If we had known that right from the beginning, I think that our process would have been much smoother.
Very good. Okay, we have a lot of questions here that are asking the price question in multiple different ways. So let me address the price specifically from an EMS perspective due to the focus of this meeting. So one of the key things to keep in mind is we really, as PulseSarah, are not selling anything to EMS. Our role with EMS is specifically to bring them to the larger healthcare team. We basically make all pre-hospital communication for free. We deliver that value for free. It's free to the hospital and free to EMS. One of the common head scratchers that we often get is, why would you do something like that? Is there not value in it? And the answer is there's tremendous value in it. But we are solving a very, very, very complex problem, regional systems of care. We're not just focused on pre-hospital communication. We are bringing pre-hospital communication to the larger table of getting a single kind of communication hub for all healthcare entities to participate in at the same time. And so if you're trying to deliver care to a very complex region, kind of a medium-sized area of like Colorado Springs all the way to massive metro areas, you're looking at 30, 40, 50 EMS agencies, 30 hospitals trying to do pre-hospital, intra-facility, and inter-facility communication. We figured out the best way to solve the bigger problem is to deliver immense value, solve the pre-hospital communication problem for free, elevate EMS to be able to participate in that greater healthcare team communication. So there's no hidden agenda. That's what it is. PulseSarah in the pre-hospital setting is delivered at no charge. The hospitals ultimately see the value of the intra-facility and inter-facility communication, and they have the option then to purchase that. That kind of ties into another question that we have, and that is, what's the process to engage PulseSarah? How long does it take to go through the process of talking to PulseSarah, go through implementation, et cetera? And then how do you manage, well, if just one hospital out of 3 wants to go with PulseSarah? I'll answer a portion of that, and then I'd like Dr. Bronsky to give his personal experience and what it was like to engage with PulseSarah, how we interacted through the process, and how long it took. But the first piece that I really want to touch on from a PulseSarah perspective is we are designed in such a way that you don't have to have 100% participation right out of the gate. Colorado Springs was amazing in the way they came together as a community and did this, but you can have it where it's not ideal for a medic, but when they're going to this facility, they use PulseSarah. When they're going to this other facility, they don't. On the other end, you have to solve the problem as well. So if a hospital has PulseSarah and not all EMS agencies are on board, they can actually start a case on behalf of EMS, so they have one way to do their job. That's also one of the reasons why we made Pulsara the pre-hospital communication for free. It was to help encourage this adoption to get everyone one way to do their job, at least for the pre-hospital component. So the next piece, Stein, I'll let you take the question really about what was the process like to engage Pulsara, how we worked together to get everyone up in kind of the timeline.
Yeah, I wish I could say with confidence that I remember the exact timeline, so I may be a little bit off here, but I do recall that when we first engaged it as a full community, and of course moving as a full community, it moved a little bit slower than it would if it was just one hospital entity. That we engaged in the late fall and at the very beginning, and then by June or the end of June or the very beginning of July of the next summer, we had our go live date through the entire community. Having this been my only experience, I would imagine from what I've heard from other communities that the process is faster when it's just one hospital or one hospital system. Of course, things always in life move slower than we would like, because when we engaged, obviously it was a fabulous experience, the initial engagement, and we had great conversations, but then everything goes into the legal mode and IT mode through the hospital systems, and those wheels and those cogs move sometimes at different speeds, and all of that does need to line up. So there's under the surface, there's a lot that needs to happen in any entity or facility to make this come to fruition. But ultimately, looking back, it was probably just over 6 or 7 months from the time where we said we want to do this to the time that we actually were going live, and so I thought that moved fairly smoothly, especially from the community perspective.
Very good. Okay. Well, thanks, Stein. It looks like it is. We are at the end of our hour, so we appreciate everybody joining us. Dr. Bronsky, thank you so much for your time today as well. Thanks again, everyone, and have a great day.